Hello, welcome to Stanford Care's monthly community health talk series. My name is Jenny Wu, and I'm a first-year PA student here at Stanford, and I'm part of the Stanford School of Medicine's APAMSA Community Outreach Board. I'm pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. You're also welcome to submit questions throughout the webinar using the Q&A function, and we'll address them during the live Q&A segment later in the program. Dr. Choi will explore how innovation and technology can improve health outcomes for Asian and Asian American children, drawing on his journey from clinical pediatrics to digital health leadership. He will discuss key challenges facing these communities, including disparities in access, prevention, and development, and examine how artificial intelligence can support child health while also addressing its limits and the need for responsible use. Dr. Ricky Choi, MD and PH, is a clinical assistant professor in the Division of General Pediatrics at Stanford University School of Medicine, where he practices in the newborn nursery and outpatient clinic and leads digital health initiatives. He previously served as department head of pediatrics at Asian Health Services in Oakland and has held national leadership roles with the National Physicians Alliance and the American Academy of Pediatrics. Dr. Choi is also head of digital health at Samsung Electronics America, where he leads virtual care strategy and partnerships to improve health outcomes through consumer technology. Thank you.
Well, thank you to the sponsors of this lecture series, Nina and Jenny and others, for inviting me to do this presentation. As I was putting this together and thinking about what we could talk about, I think I realized there are a lot of questions. There are a lot of needs. There are not a lot of answers. And I think I spent a good part of my career trying to figure out how do we start to make things better for people. And I think in my journey, I started to find ways to go about it. But I think it's a little bit of a punt. But I'm hoping that through this presentation, it can start kind of turning the gears in all of your heads so that we can all think together about what those solutions could be, about addressing a whole range of needs. When we talk about pediatrics specifically, API communities specifically, and then the new opportunities that are being created by technology. So, needless to say, just as a disclosure, in addition to my role at Stanford, I work at Samsung Electronics America. And so during this presentation as an overall agenda, I wanted to share a little bit about my career journey and some of the choices that I've made and why I made those choices. Talk a little bit about API child health. And it sounds like there's not been a lot of conversation about pediatrics or child health. And so really hope to help all of you understand the tremendous need when it comes to child health. All of us were children at one point. The children make up, a huge part of the American community, but will be 100% of the future. So I think it's something that we should all be thinking about and think about how we invest. AI as relates to child health, and then maybe some conclusion thoughts and maybe some questions if we were open to have a discussion. So I think that as I look back in my career, and I'm still going through this process, trying to learn more, do more, figure out what that right place for me to make a difference is. It always helps to start from kind of my roots as well as kind of trends. And if I were to think about kind of the trends about the choices I made, I think the reoccurring themes were around service, around scale, innovation, and ultimately impact. And I think it helps to understand that, when it comes to kind of my growing up, my dad is a social worker. He's now retired, but he's retired as a professor of social work. My mom is a nurse, also retired now. And so I grew up in a home that heavily prioritized service and caring for other people. I think faith was a really big part of it, but also just a sense of duty and obligation, and that's what we're meant to do. And I think I took that on. Also, my wife, who is as a preschool teacher. She has a master's in early child development and currently she's a part-time teacher at Stanford's nursery school. And so you can kind of get a sense about kind of how we're oriented, what's important to us and our values. I went to undergraduate school at the University of Chicago, which really helped support my approach to thinking in a very interdisciplinary way. I was really inspired by the idea that if we were to look at the intersection of multiple disciplines, we'll start to be able to unlock and address longstanding questions. And for me in particular was around health and healthcare and medicine. I went to medical school at the Medical University of South Carolina, and I went into medicine because I felt like that was the most direct and immediate way I can impact people's lives. Contrary to a lot of Asian parents, my parents didn't say you have to go to medical school, but I was certainly drawn to it because of that. But through my medical training, I realized, yes, it's super important to address the needs of the people right in front of me, but I was really interested in thinking about things more upstream, thinking about social context, communities, and et cetera. And so that led me to then take a year off of medical school to get a master's in public health at Harvard. And upon completing both of those two programs, I started to figure out, okay, where's the best place for me to start doing my residency training in pediatrics? I knew I wanted to be a pediatrician because I felt like that I had an orientation towards public health, an orientation towards prevention, but I just got excited about thinking about my patients in the morning during my pediatric rotations in medical school. And I was also very much drawn to the needs of underserved communities. And so as I was applying for residency, the UCSF had just started a new program, UC San Francisco, around pediatric leadership for the underserved, which I'll tell you a little bit more about later. But suffice it to say, it was a fantastic program for me, and according to my needs. I went to a community health center called Asian Health Services, which I'll share a little bit more about that in a second, and became the head of pediatrics there. I got to a point where after about nearly 10 years, I said, gosh, I'm really feeling that itch again. Every morning I wake up, I know exactly what I'm meant to do, the value of what I do, the impact I make on my patients, really incredible relationships with children and their families. But I really felt like I don't know if I can hit scale this way. And, you start to run into feelings of, well, there are a lot of things that aren't working in the healthcare system today. The patients I was seeing there were definitely the people who are often left behind or ignored or marginalized. Isn't there another way we can approach this? And I started to think about what's the opportunity when it comes to scale and where can I find innovation? Could it be outside of the healthcare system? And so after a long search, I ended up finding a position at Samsung. For me, Samsung represented innovation, it represented scale, and the kind of impact that I knew that I could make at a scale that I could never achieve by seeing patients one-on-one. Now, the interesting little variation on that was that job was in South Korea. And so after a long family discussion, we decided at the end of 2015 to move to South Korea, my wife, my 3 kids, and myself, and embarked on a completely new trajectory in terms of work. Learning how to function, learning whole new skill sets, things that were never covered in college or medical school, but understanding business, understanding how businesses work, how technology is made, the processes to build these technologies, and et cetera, and the potential scale opportunities to really deliver on massive impact. At the middle of 2019, I moved back to the United States for a variety of reasons, including professional ones. And upon coming back, I realized I really did miss seeing patients. I'd taken a couple of years off. I was still getting texts from my friends and family for advice on how to take care of kids, but I really wanted to see patients again. And so joined Stanford as faculty and continue to see patients today a couple times a month. And continue my role at Samsung, where I'm now the head of pediatrics, leading digital health initiatives. And so now I'm back in the United States and I have these two, I have my doctor hat on, but a whole new skill set and a whole new way of looking at the world in terms of digital health, and started to think a little bit more about why are we not seeing a lot of digital tools when it comes to pediatrics and child health? And so helped launch kind of a digital health task force in our pediatrics department to think about those things. And I'll share a little bit more about that as well. So let's talk about child health a little bit. Now, I remember when I first met my father-in-law, and I was actually seeking permission to marry my wife. And he said, "So what are you going to do?" And I said, "Well, I'm going to practice pediatrics." And he said, "But kids don't get sick. So what are you going to do?" And I realized that not just him, but many people there's not a general strong awareness about the health challenges, that children face today. So we have seen, in the last few decades, a massive rise in asthma and diabetes and obesity. 32% of children and teens are either overweight or obese. And we know that children who are overweight or obese are much more likely to have overweight and obesity challenges as adults. 20% of children in the United States have special healthcare needs. And so, they have, whether it be anything from ADHD to asthma to some kind of rare disorder, they're going to need a little bit more help than a child without those needs. I think all of you are very aware of the significant challenges when it comes to mental health. 42% of high school students have felt sad or hopeless during the past year. I think there has been dramatically more attention placed to mental health during and after COVID, and not listed here, but there is a massive shortage when it comes to practitioners who can address the needs of mental health needs of children and young people. And 8.3 million children and teens struggle with anxiety or depression. We know that socioeconomic factors and health disparities, right? We know that about 4% of children under 18 are uninsured. So in effect, doors are closed to them to address their health needs, to get the routine vaccines, and et cetera. We know that about 86.8% of Latino and Hispanic children, 89.5% of white children have had a well child check in the past 12 months. And so in child health, these well child checks are kind of the bedrock and cornerstone of child care. It's when we do screens for things like lead poisoning, vision, or hearing. It's when we give routine vaccines. It's when we start checking in to make sure children are developing and growing normally. And we're seeing that even to think that, a 1% is still too many. And I don't think that people realize that we have huge numbers of children who live in poverty, 16% of children living in poverty. I mean, I think for anyone, it's just the worst thing when we think that a country can't take care of its own children. But in the context of crisis of a broader healthcare system that's under tremendous stress, for those of you who are paying attention to the needs of the healthcare system, there are tremendous levels of provider burnout. And this is not just in pediatrics, but across all specialties. There are projected massive shortages when it comes to the healthcare workforce. The cost of care continues to rise dramatically. I'm sure somebody's mentioned this already, where we're spending just outlandish amounts of our gross domestic product on healthcare. And we're not getting a good ROI on that investment. The return on investment is poor as we look at overall outcomes in healthcare. So it's in that context that I thought, okay, I want to go to a program that will train me to be a pediatrician that can really address the needs of underserved communities. And I think that what really got me excited about this program at the University of California in San Francisco, that it was very focused on exactly that. I think when we think about children, they're inherently dependents. Someone needs to take care of them. And so when we're thinking about children, we're thinking about that 1-year-old. We're thinking, that baby that's being held, the 3-year-old who's trying to walk around and can say a couple words, the kindergartner who's starting to learn how to behave in class. We're talking about 10-year-olds, 15-year-olds, teenagers, sexually active 16-year-olds, young adults learning how to become adults. That whole range, right? They are, and the younger they are, certainly, they are dependents. They rely heavily on the care of the adults around them and the environment they live in. And so then when we talk about the fact that 80% of health is really comprised of non-medical factors, where you live, the housing conditions you live in, the lead that may or may not be in your paint, and the paint on the walls of your home. We think about the things that injure or kill children. Those are social factors: gunshot wounds, car accidents, suicide. those are all leading causes of death, the top 5 leading causes of death when it comes to child health. And so this program was very much focused on helping us understand the relationship between those social determinants and the child health that we're seeking to address in our clinics. And so it included tours of the communities in San Francisco, the public housing areas, the communities, the minority communities in Chinatown, which live doubled up and tripled up, where you have multiple people living in extremely small spaces. The concerns about environmental toxins, and in historically old shipping yards in parts of San Francisco, and thinking about how do those things come together and manifest in what we see in clinic. And so a lot of my training during this time was then at San Francisco General Hospital, which is the main public hospital in San Francisco. So as I was coming out of this training, I thought really carefully, so what do I do next? I could work, in some of the most challenged neighborhoods in San Francisco. And I thought, okay, where is the best place for me to be to make the biggest impact? And those communities, that kind of pop up when you talk about San Francisco are dominantly either Black or Latino, and tremendous needs, really incredible work to be done there. But I thought, when I look in the mirror, what I look like, and I think about my personal history and who the communities I can best represent, it seemed to make sense for me to look someplace else. And I heard about this health center in Oakland called Asian Health Services. And the way that somebody explained it to me, it is like a one-stop shop. It provides direct care for patients, all the way to providing community activism to shape the urban planning in the communities it's around, all the way to participating in engagement and policy at the state as well as national level. And for someone who just got out of training about thinking about social determinants of health, with a public health background and medical training, this feels like a slam dunk. This is the place I need to be. It was really apparent for me. And I felt like that this would best position me to make the most impact that I could make. So let's just talk a little bit about Asian American children. In the United States, there are about 4 million Asian American children, and they are one of the fastest growing racial ethnic groups in the United States. And as I'm sure you've heard over and over again in past lectures, in which you already know, it's super important to start disaggregating data because, as we know, the Asian American community is extremely diverse. And not surprisingly, California has the most Asian American children. I think it's helpful to look at California and specifically as being the most popular, having the most Asian American children, but also because the way that CHIS data is collected, it oversamples for different ethnic groups. And so it can start to get at some of that disaggregation. And so from that study, that regular survey, 17% of the state's children identify as Asian American. And even within this group of Asian Americans, 1/3 of youth report feeling depressed. 97% of Asian Americans have health insurance, but 26% are enrolled in Medi-Cal. And for those who are not from California, Medi-Cal is Medicaid. We in California, we like to put Cal on everything, Caltrain, Medi-Cal, et cetera. But let's just be clear that it's Medicaid, which is a state federal matched public program for low-income communities. And so we're saying 26% of these kids are low income. Now, dental health, the number one infection when it comes to children, 70% have untreated decay and 50% have tooth decay, compared to whites, as you can see, significantly more. And while we can say, oh, you have cavities, your teeth will come out eventually, get adult teeth. I think we have to recognize the importance of dental hygiene because it's critical for whether we think about pain in the mouth, think about speech, all these sort of things are going to be challenged when you have dental health problems. And I think it's also helpful to keep in mind that when it comes to adults, a lot of times we assess adults in terms of how productive they are in society, their ability to work, the number of sick days they have, that sort of thing. When it comes to children, we have to think about it in terms of their ability to go to school, because their job is to go to school, to learn, to set that foundation so that they can have a profession, the career that they want and the life they want in the future. And so, as you can imagine, if you have a lot of pain in your mouth, you're not going to school. excuse me. 46% of seventh graders have been harassed or bullied in school, amongst the highest of any ethnic group. 10% live below the poverty level, and and some segments more than others, including the Hmong and Cambodians. And 1 in 4 live in a household with a primary language other than English. And some of you may be aware, obviously language access is a critical part when we think about the range of needs that affect our communities. But if you think about the role that children end up playing when they're the primary English speaker, I once had a third grader. It was a Mongolian family in my clinic, and he was doing the taxes for his family. Right? Is that appropriate? For a child, an elementary school child. So I think that we have to continue to think about those things, and then there are also a whole lot of other dynamics when we think about the bicultural aspect of it, where children are being raised in an American environment, but when they come home, they're living. When we're talking about immigrant families, then there's a different cultural environment at home and different expectations, community challenges, and et cetera. So just a lot of things going on there, and some of these things that some of you may know personally and may have experienced. So let me tell you about this community health center. This is the most recent stats. They served at least 28, almost 29,000 patients in the area. They're located in Oakland, Chinatown, but that area in downtown Oakland happens to be a hub for a range of Asian communities. And the East Bay, that whole Oakland area, is extremely diverse when it comes to Asian communities. About 37% are elderly, and nearly 20% are pediatric, and 92% are in Medi-Cal and Medicare or are uninsured. And so these, this clinic qualifies as what's called FQHC, which is one of a category of clinics that are available throughout the country, meeting the needs of underserved and low-income families, whether it be in rural populations, whether it be in urban populations. There's a system of clinics, a very well-known one, Hawaii, in New York, and other areas where have high concentrations of Asians, that's serving the needs of low income. But this clinic, on top of being low income, is serving the needs of new immigrant populations in particular. In 2024, it had about nearly 150,000 patient visits. And as I alluded to before, language access is a critical piece of the services that they offer. In fact, it's kind of a key part of all the services they offer. And so the way that looks is when I'm seeing patients, and I saw patients who spoke any of 10 different Asian languages when I was there at the time. I had an in-person interpreter standing next to me. I speak English and I speak Korean, but when I had a patient who spoke Cambodian, who spoke Lao, who spoke Mien, who spoke Mongolian, who spoke Tagalog, who spoke Vietnamese, Mandarin, Cantonese, and et cetera, I would have an interpreter next to me to provide in-person interpretation. It was and you can imagine, as we tried to make it a very culturally friendly place, we would have we'd have like the hand sanitizer, and next to it say hand sanitizer, and then below it, written in 10 different Asian languages, hand sanitizer. But all to say that emphasis on language access really being critical. And what that led to is us being kind of a cornerstone to the way that people navigated their health, because they knew they could speak their language. They felt that with that the cultural competence and willingness to engage, and they would come to us first. And so in many ways, I felt, and they didn't have a lot of other choices, or maybe I felt they didn't have a lot of other choices in terms of feeling that comfortable. And so it would come to us for everything. And so I almost felt like a small town doc, because I had patients who came for a regular cold, some patients who had a really bad cut, had a broken arm, and in some cases I had patients who came in and I later found out they had cancer. And so they offered this kind of get to see everything, because the patient felt so much, they relied on our clinic to such a degree. 70% of the patients are less than 200% of the federal poverty level. I think the 200% would be about $63,000 a year for a family of 4, and 70% were making less than that. And so a lot of these families then were people who are restaurant workers, and had odd, unsteady jobs and income. And so you can imagine then the challenges that come with making appointments, being available, their ability to leave work to come to a doctor's appointment. All those different things kind of play into the dynamics of what we see and building services to help support their needs. And so they offered a range of services, obviously adult and geriatric care and pediatric care, but we had a dental clinic for all the reasons I just mentioned earlier and the importance of offering that care. Mental health challenges, as I mentioned before, we had behavioral health counseling as well. We had school-based clinics, nutrition clinics, and et cetera. And beyond that, and specific to really the needs of our community, we had some really special programs. Bante Sray, who was creating communities and support networks for sexually exploited minors. We had a nail salon collaborative that to help owners and their employees live in healthier environments. And let me just kind of double tap on that for a second. Nearly 80% of the nail salons in California are owned by someone in the Vietnamese community. And so this is a problem specific and in many ways very unique to into Asians, for example. And so in that way, looking at the needs and the way that people live and work in our communities, identifying opportunities to try to improve, their health conditions, their work conditions, so that we can live healthier. And let me I'm going to circle back real quick on the nail salon aspect. I think one of the things that we were working on is good ventilation. As you can imagine, a lot of these nail products have a lot of toxins in it. And the people who are working are typically women of reproductive age. And so you can imagine then the concerns when it comes to toxic, the negative ways it could affect the unborn baby. And so, that has served to be, it's a collaborative that's gone on for quite a while and super meaningful for those communities. And so, I was seeing patients there, full time. And I use that opportunity to say, okay, I'm in this really interesting microcosm of patients and a range of needs and challenges that I'm seeing every day. I'm not hearing enough about what are we doing to improve immigrant child health. I started working within our physician association called the American Academy of Pediatrics to start updating policy, starting to kind of bring awareness to the needs of immigrant child health. Other matters to consider about are at that time and still today are unaccompanied minors, legal status, insurance access, all those sort of things. And so a lot of conversations and policy development around that. But it was also around that time as I was trying to figure out how do we help our patients be healthier, that even outside of my direct physical interaction with them. It was around that time we started doing email with patients, but even that was restricted as we were trying to figure out how do we keep data safe and private. But what I did notice was that around this time, this is the late 2000s up to the mid 2010s, that all of my patients had a smartphone. I had patients who did not have enough money for Christmas presents, but they all had a smartphone. And that kind of spoke to how important smartphones were in order to live, to get a job, to keep a job, to go to school, to stay connected. And these are immigrant communities, so they're staying connected with their families, not only locally, but also globally. And I think I had a moment where I realized, okay, if I really want to move the needle in health and do this in a scalable way, I think consumer technology may have a role to play. And that kind of motivated me to make that next step to figure out to switch, to make a transition professionally in terms of digital health. So when I joined Samsung, in my mind, it was, again, as I said before, how do we do things at scale? How do we drive innovation in those experiences? And I think what got me excited about consumer technology is that people know how to use it. It's not some strange medical device that you have to learn how to use. You might be uncomfortable with, that you don't want to wear in public because it says I'm sick or I'm frail or I have a health problem. Consumer technology is already in people's homes. They know how to use it. It's already part of their life. And so, something like, Samsung, for example, it's like in 70% of American homes today. So my job is to start to think about how do we then connect these things together to better understand user needs, guide them and nudge them and support and encourage them to do the healthier thing, tie them into care then when they might need it, support them and when they return home from a clinical setting. And we can think about the role that the refrigerator plays. in terms of food that you have there? Can we create ways to automate, food delivery, and restock it? Can we come think about ways to guide people to stay on their diabetic diet, their heart healthy diet, and et cetera? To what extent can we look to wearables to help us understand what's going on in our bodies, understand things that typically get data, the kind of data that typically we'd only get within the four walls of the hospital? And we started and made a lot of progress in that way. And so, joining Samsung then kind of helped me think a little bit differently about that whole health and healthcare process, right? There's you can imagine it like tracking and measuring, with a smartwatch, for example. Some of you may be using those types of technologies. Are you taking enough steps? Are you sleeping well enough? What's your stress level? And then going on to then early signals. We have capabilities to detect for moderate to severe sleep apnea or having certain cardiac conditions. You can imagine a step where technology is supporting the diagnostic process, whether it be through telehealth or some kind of technology that measures that, facilitating treatment, either helping you to stay on track to take your medications, or now there are treatments, for example, some mental health challenges as well as insomnia that are delivered entirely through a digital tool, as well as disease management and remote patient monitoring. There are many conditions. There are, some conditions, you'll get and they'll go away as they've been treated with antibiotics or whatever that management might be, but many of which will stay with you for many years. And so there's a whole process of tracking, measuring, as well as ongoing education around that. So in that context, I've been, having a chance to think really a lot about the role that technology can play and how it can fit into your life, right? And so circling back into child health, I think that in the last few years, I think everyone has been really excited about the role that AI could play. If you think about what AI does well, it can take a ton of data, it can connect the dots to help you understand how that data might be related to one another. It can compute at extremely high speeds, at just an incredible capacity to compute, and then offer guidance of what we might do. And so we think about child health and the things that affect them, affect children. We can imagine then that digital technologies could play a really important role. New next generation diagnostic capabilities, right? Being able to connect the dots on social determinants of health and how that may tie into a particular health or health outcome. We can think about development of new drugs. We can think about, telehealth and tying people, as well. And so I think that AI starts to unlock a whole lot of possibilities in terms of helping people from that measurement to diagnosis, or rather, let's start with prevention and then early detection, diagnosis, and management as well. And there are current, and even before AI in the current landscape, there are still many challenges when it comes to be able to identify disease, diagnose them, and et cetera. And so there's an important role to play here. And so if I were to use a couple of examples of where AI is actively being used, or under increasingly valid research, is, for example, asthma, right? One of the challenges when it comes to asthma is that it's not uncommon for children to have wheeze when they get a cold when they're really young, but only a subset of them develop to have kind of persistent asthma or asthma that kind of stays with them in adolescence and adulthood. And there are algorithms to help detect that, algorithms to help detect weather patterns and different conditions so that people can start to predict the number of hospital admissions we might get from asthma. When it comes to autism, for example, there is a company that has created an FDA-cleared solution that takes data from parents and takes data from other caregivers and then analyzes video to basically help facilitate the diagnosis of autism, shortening what typically can be a multi-year journey down to just a couple days or a couple weeks. And in terms of radiology, there's our ability to be able to see more than what the current screens, the X-rays and MRIs and et cetera are showing us continues to grow exponentially. I think when it comes to child health and radiology, there are a lot of kind of nuances when it comes to being able to understand if there's a fracture or not, or is this something we need to be concerned about or not. But certainly bringing AI to it certainly is certainly advancing our ability to provide better, higher quality care. And AI, you may have heard about some of these things, is already in place for some of these other areas, such as ambient scribes. Essentially, imagine having AI with consent, listening to a patient checkup visit, taking notes, and helping to pre-write or at least put the first draft of a note for the doctor. And so the doctor can spend a whole lot less time typing and trying to fill out forms and can spend more of their time focusing on and engaging with the patient. And frankly, when it comes to pediatrics, that's like the funnest part. Talking to a 3-year-old, talking to a 5-year-old, and hearing what comes out of their mouth. There is increasingly becoming part of other administrative things such as reducing errors and tracking and reducing errors within the hospital system. One of the biggest, when I spoke about burnout earlier, biggest challenges in health and being a doctor in healthcare delivery is just the pure massive amounts of work in the form of emails and getting request permission to be able to give your patient a particular kind of drug, as well as collecting registries and et cetera. And so already starting to play a role. And you might have heard about all the different ways that AI is already being used in other parts of care, but I would argue that kids are still being left behind. And so if I were to offer kind of a slightly different take, away from clinical, but actually moving it from a kind of a business perspective, pediatrics is just not viewed as an attractive market. In general, money is spent on things, on sick care, right? Cancer, heart attacks, strokes, back surgeries. That's where a lot of the money is spent, and investments in technology is usually on ways to try to figure out how do we use technology to reduce doing those sort of things. Now, fortunately, while children, as I mentioned earlier, do struggle from a number of health challenges, it doesn't end up being expensive at the level that we talk about it for adults with cancers, for example. And so it's viewed as a smaller market and therefore not as attractive. Because imagine if you're trying to create a new business, you kind of want to go where you think the financial opportunity is. The other thing, too, is preventive care. As I mentioned, is a cornerstone of pediatrics, doing these screens to make sure that, or to check on if children are developing appropriately, talking at the right age, walking at the right age, looking to see if they may have early other conditions like autism, getting their vaccines, getting their dental checks, and et cetera. Not as prioritized in American society. It's often under-incentivized and hugely underfunded. Now, over the years, and rightly so, I think that regulations have cropped up to try to protect children more and putting a little bit more of a burden on tech companies to make sure that they're developing the right thing, which I think is absolutely the right thing to do. Industry will do what it does, which is try to figure out how to make money. And so whether it be through regulations or otherwise, we need to figure out ways to set the right guardrails. From a business perspective, if you can choose to develop something that could be for adults that may have fewer rules around it versus for kids who have a lot of rules around it, I think one's going to seem like it's going to be more efficient, cost less to develop, and a little bit easier to get after from a business perspective. Pediatric data management is tricky, right? Who owns that data, especially for minors? And that transition when, and I mean by child or the adult, but when that transition as they become teenagers and become independent, there's just a lot of complexity there when it comes to how to handle that data, the right consents, and et cetera. As I mentioned before, 58% of child health is covered by Medicaid, 67% in California. Again, if you're creating a business, generally you go to places where you can find people who are willing to spend money, or there was a pot of money that can be spent towards the solution or whatever service you're creating. So again, less attractive. The needs of children change with age. The needs of a 1-year-old is very different from a 5-year-old versus a 12-year-old versus an 18-year-old, right? The way they interact, their size, all those sort of things are considerations. Again, making it difficult. If you're creating a business, less variation is probably better. So you have to make fewer things and you can focus on that one thing. And as I mentioned before, children are dependents. And so then, you're not just trying to design something for that child or that particular user. You have to think about their parents, their guardians, their teachers, all those other components. All to say that, from a business perspective, then pediatrics looks awfully unattractive, especially when given other options. But when you look at it in its totality, then it certainly leaves kids behind. So at Stanford, we've been thinking a lot about this in our general peds division. You know, we live in Silicon Valley. We work. Some of us have relatives or spouses, or we ourselves, are involved in technology in digital health in some way or the other. But we realize that there are tremendous child health needs, but they're not being addressed for all the reasons I just described. What is the problem? How do we understand that problem, and how do we make it easier for technology we develop for children? What needs to be created? Do we need to better understand the digital health landscape? Do we need to better understand the health economics? And how do we create the right incentives to drive business to address the needs of children? So we have a group of us that have been gathering on a regular basis to really think about that and to start to speak about it and start to kind of communicate more and try to engage industry more so that we can start to move the needle when it comes to child health. So I feel like I kind of went a little all over the place, and that's kind of the career that I've led. But I'm not done. Like in terms of answering my own personal questions, kind of meeting my mission, and the career steps I'm hoping to continue to take. But hopefully that you kind of caught kind of through that a kind of a through line that goes to, look, there are tremendous health needs in this world. At least I personally feel a responsibility to start to address them. Healthcare, direct healthcare is an incredible and meaningful way to do that. But there are other angles to take when we think about how do we start to do that at scale, and whether it be through technology or through public health. And there are tremendous child health needs that can't be ignored, whether it be from social determinants of health, such as poverty and housing, all the way to a whole range of health conditions. And what does that mean for policy? And then, as we all know in this audience, Asian American children are not exempt from these challenges. In fact, have unique challenges to consider. And so when we think about the power of AI, the ability to do things at scale and yet offer kind of precise personalization. When we think about language access and the role that AI could play to offer translation, to help get to adjust language to an appropriate literacy level for the listener and their own personal experience. We can imagine a whole bunch of ways that AI and other technologies could really make a difference for care delivery, for research, as well as community outreach. And I think it's worth considering and discussing. And what other special considerations should we be made to help address the needs of these communities? I urge all of us to continue to think, noodle, and challenge ourselves to try to find some of these answers. Thank you very much.
All right, now we can transition to the Q&A section. And just another reminder for everyone to use the Q&A function at the bottom of your screen to submit any questions. But we do have a few pre-submitted questions that we can start with. The first one that I have is one of the participants was kind of wondering your thoughts on immigration history and risk of allergies prediction.
Yeah, that's super interesting. When I was living in Korea, it was very much like what I heard from my patients, which is no one has food allergies, in Korea. It's not an absolute fact, but it was kind of just general feeling of food allergies are not that common, but in the United States, extremely common, right? Peanut allergies, eczema, asthma, all that kind of all these kind of related illnesses. And I very much saw that in my clinic, which was entirely Asian American. So I don't think we still understand exactly why that may be the case. I think that that people are continuing to shift things around in terms of the guidance about how to care for children, so that we can avoid the risk, reduce the risk of allergies or food allergies in particular, and also keep them safe. And so, for example, when I was training in pediatrics 20 years ago, we were taught that we're supposed to introduce foods in a certain sequence. So let me back up a little bit. Most babies, all babies, after birth, they largely drink milk, right? Whether it be formula or breast milk or something along those lines. And so when you get to about 4 months old, you're supposed to start introducing solids. Now, the concern is that you don't know if this child has any food allergies. You just don't know. And so obviously there's a little nervousness about what to introduce. And especially for families who have a family history of food allergies, they're going to be extra concerned because they may have a story about someone getting very, very sick because of that. And so it used to be that you would delay certain foods like peanuts to the very, very end, not whole peanuts, but pureed peanuts that young children could consume. But that some of that guidance has really changed. And I think we're looking to see if that makes a difference in terms of the rate of food allergies.
Thank you. We have another question that was just submitted, and it says, what are some promising strategies you have found to engage industry to invest in pediatric interventions?
Yeah, I think that when it comes to digital health, it's very much like the trends that we've been seeing in medical devices, as well as drugs for children. For almost the exact same economic factors, there have been not enough drugs, especially for children. And we're talking now for more serious conditions like seizure disorder, certain cancers, and et cetera, for which there's just not a huge number. So again, imagine, put your hat on and say, I'm a business owner, I'm a drug manufacturer. Am I going to pick the drugs that are only going to benefit a smaller group, or am I going to, what I want to make a drug that benefits a lot of people? In order to combat that, I think the FDA, for example, has created special incentives and fast tracks to make it easier for these pharmaceutical companies to produce, test, and launch those drugs. And I think that those need to be special considerations when we talk about medical device as well as digital health. Now, absolutely, we need to think very carefully about that tension between speed and safety and efficacy. Efficacy meaning it does what it said it's supposed to do, but I think that we need to find that right middle ground, so that we're not, giving children drugs or technologies that are not meant for them, and have not been at some level tested for them, so that and we don't want to take life-saving or just keep technologies and medications that can relieve significant amounts of suffering, out of their hands, but kind of get to them if it could be helpful as soon as possible.
Great, thank you. The next question states, my daughter has had eczema for a long time. The doctors here have always said to keep her skin well moisturized and prescribe some steroid medications, but it hasn't really cured it. However, a friend went back to China and was prescribed medication there, and her eczema got better. Is this because medications are prescribed more cautiously in the United States?
Yeah, so I can't speak to this child specifically, but in general, I think that that medical care would be around making the skin as healthy as possible, right? And so that means good moisturizing at baseline. It's kind of like, I'm sure many of you are, I know that a lot of young people these days are paying a lot of attention to their skincare, right? And so you need to then wear sunscreen. You need to keep moisturizing. You need to do all those different treatments. Maybe not 18, but you need to do something to make sure that you kind of keep your skin healthy. And so you have to do those basics first, right? And then start tracking situations in which things get worse and get the right level of medication to address it. The challenge when it comes to steroids, and there's a whole range. There's very weak over-the-counter ones and very, very powerful ones that can make skin thin and cause discoloration. You need to find the right level to treat that matter then. But the challenge is as soon as you stop it, it could come right back. And so I think that it's always a little bit of modulating given the right situation, the time of year, and then maintaining that basic care of your skin.
Okay, and the next question is, from your experiences in South Korea versus the US, was there any difference in the speed of process for the development of products or innovation?
Yeah, that's a good question. And I don't think I can really offer a strong comparison. But some interesting dynamics to consider. In South Korea, as with Canada and many other countries, they have a single payer, which is the national government pays for healthcare. Now, they can go to a private institution which will in turn get paid by the government. So it creates a very interesting dynamic where then access is really not an issue, but and therefore telehealth really doesn't. I mean, except for the pandemic, really not a thing. In fact, if telehealth is nearly illegal in South Korea because the physicians union is quite strong and prevents it from kind of get adopted. But at any rate, when we think about the triple or quadruple aim, quality, access, costs, and patient and physician satisfaction, access is not an issue there. They're a high volume type of experience. And there are then on top of that, as with many other single payer countries, they also have an ability to get a kind of a concierge or an additional layer of healthcare on top. I don't have but to answer the direct question, I'm not sure. I think part of it will have to do with investment. I think in the United States, we do more, whether it be, venture funding, whether it be government funding, NIH, et cetera. The funding environment, I think, is much stronger in the United States versus Korea. But if that trickles all the way down and on what metric we would define speed, I'd have to think about that a little more.
Great. The next question is, the participant is curious on your approach to making wearable technology or AI-based technology more accessible to harder to reach AAPI communities that do not reside in cities that are relatively larger technology hubs.
Yeah, I think that, when I first started in clinic was in the mid 2000s, and people were Googling everything, right? And now we're at a place where people are using Gemini or ChatGPT to start getting their questions answered. I think that these are, in effect, directed at consumers. This goes back to why I'm kind of excited about consumer technology, because of its ubiquity, because it's easy for almost anyone to access. Now, some of these things might have a cost component, but you don't have a gatekeeper. You don't need a prescription, to be able to do those sort of things. And so I'm excited about the role those technologies can play to then offer guidance at a literacy level and potentially at the right language to meet someone's needs. Now, as with anything, and this is, there is this kind of old adage that says that if you're not paying for the product, then you are the product. So what I'm trying to say is, companies like Google, ChatGPT or otherwise, or OpenAI, if you're not paying for it, they're making money somehow. And so they're maybe making money off your data, showing ads, whatever that may be. So we need to go into those things with our eyes wide open. And if the value, what you're getting back for it, is worth it to you, then good for you. But no matter what, I think it's important to keep our eyes open in terms of being well aware and not naive about the models that they're using in order to enable those technologies.
Great. There are also a few more questions regarding South Korea. The next one is, can you talk more about what additional cultural practices from South Korea that you continue to adopt in your clinical practice and work today?
So in Korea, I wasn't practicing at all, except for, as I was saying, over text when my friends when their kids had some kind of health problem and they wanted to kind of curbside me. But I do think that being in Korea, understanding the culture even deeper in modern Korea. Korea is not, today is not the same Korea as the Korea that my parents grew up in. Is just, I think, recognizing how people communicate, what people mean by what they say, and kind of the importance of kind of relationships and the other people that are playing a role in their care. I think that in any kind of interaction, any cultural interaction, I think listening is super important, but also starting to read the trends. And so Korea is kind of a unique place. I think Korea, Japan, China, and some of these other countries, it's extremely homogenous. Somewhere near 97% of South Korea are Koreans, right? And so then the way that communication is done, the expectations are when you compare to a US standard, are quite homogenous. There's an expectation that there's a sequence of things that will happen. And if you were not to do those things, then something has gone wrong in the interaction. So let me just give you a weird example. Like if my colleagues go out to have lunch and I don't offer to have coffee afterwards, they're going to get upset because they said, "Oh, did something happen that the natural next steps didn't happen?" And that is a common and shared expectation. Now these shift over time, but my point is the homogeneity of that kind of thinking. In the United States, it's so diverse that everything needs to be very explicitly stated out loud. Is it okay if I touch, your arm? This is what I'm thinking. Everything needs to be very explicit and out loud because we can't assume anything about the patient, what they want, and what they want, and what they would assume from me. And so I think some of those dynamics, I think, help me understand the range of ways that I need to communicate with my patients. So those are a very long-winded answer, but hopefully there was something there that was helpful.
Great. Yeah, I think we have maybe time for just one or two more questions. The other question was, you mentioned the physicians union in South Korea protecting the physicians' interests. Do you see a possibility in the US for unionization of physicians to prevent burnout? Or does the absence of single payer slash homogeneous healthcare essentially render it impossible?
Yeah, that's a great question. And so I think that there's two parts of that. One, there is a union for residents. So those are, you finish medical school, you go do your residency, and there is a union in some hospitals, medical centers, for residents. And I think part of that has to do with pay, part of it has to do with work hours, and a range of conditions to make that very challenging part of training livable. I think when it comes to clinicians, it's a little trickier because physicians are extremely devoted to their mission about caring for people. And so if I remember when I was a kid in a public school and there was it's the teachers union decided to do a walkout. And so all the teachers left. I think physicians would have a hard time allowing that to happen because then who's going to care for the patients? The nurses have done a good job at unionizing. They know that there are strategies that health systems can take to fill their spots. I think for whatever reason, physicians are not willing to take it that level. But I think something needs to be done when it comes to the workforce, burnout and the workforce shortage. I think that I think it's a illness of the healthcare system broadly. I would hesitate to blame it entirely on the administration of the hospital, but I think that nearly everyone I know I've spoken with would agree. There's really no way out of this without looking to technology to help us address some of these things, to drive more efficiency, to get patients to the right level of care they might need it, so that they have a more direct path so they get their health needs addressed sooner, so that that physicians can be more efficient, and along those lines, trying to relieve some of that pressure.
Great. There are a few more questions. Would you like to maybe answer one more, or should we just?
Sure, let's do one more. Yeah.
Okay, great. The last question we have is, do you have concerns about AI hallucinations that families, AI, API included, may be exposed to when seeking their current health questions? Should companies have a stronger disclosure for cautioning consumers?
Oh, absolutely. And I think the more sensitive and the more the topic and the fewer options that for a given question domain topic that person has to verify that, the more sensitive it becomes. I think that hallucinations will continue to get better. There are technologies and approaches to try to tighten that up. But I think that there's a point at which we're going to accept it. And what I mean by that is, I don't know if any of you ever read Wikipedia. We all know that it's crowdsourced. We know that it's like not going to be 100% correct, right? But we kind of like, okay, I think I kind of get the gist. And I have a feeling that for some of this AI work, we're going to look at it that way, that we're going to know what to do with that information. I'd love to say that doctors are perfect and are always right. We are not. Now, and when you talk about lab tests, we talk about X-rays and all those sort of things. All of those have a margin of error as well. So I think that we should have a reasonable expectation for AI, physician error and AI error are not the same things, but from the expectation perspective, they are they can be viewed. I can imagine them being viewed similarly, and so I think that we need to continue to engage to get those technologies to be as perfect as possible and in an ongoing into the future way. But I think that if we understand the value that we'll get out and know what to do with that information, I think that we'll be more informed, people. And you can think about commercials, ads. There's a lot of, and in this very interesting time we are in now, there's a lot of misinformation. I think that we need to continue to educate people so that they know how to take some of that information and process it well.
Great. Thank you so much for answering all those questions and also presenting today. I'd also like to thank the attendees for asking questions as well and attending today. Nina has shared in the chat regarding the upcoming webinar, and we encourage all of you to join us for the future events. Thank you all, and I hope you have a wonderful rest of your evening.
Thank you, everyone.